We're recording now.
Great, thank you. Welcome everybody to this Zoom conference today to launch the Chronic Injustice Report, centering equitable healthcare and policies for COVID-19 and other chronic conditions. My name is Jeremiah Johnson. I'm the HIV Project Director at Treatment Action Group here in New York. I am also a core facilitator for the COVID-19 Working Group New York, a coalition of doctors, healthcare professionals, scientists, social workers, community workers, activists, and epidemiologists committed to a rapid and community-oriented response to the SARS-CoV-2 pandemic. I'm going to paste in the website for the main group here in just a second. This report is being put out more specifically by a subgroup of the COVID-19 working group, the healthcare access subgroup. And we're very proud to present this work today on an important issue and efforts to call out a long-term and comprehensive response to all of the ramifications and all of the ongoing consequences of the COVID-19 pandemic. Before jumping into the report and introducing some of our speakers, I do just want to briefly turn your attention to a few procedural items that you see on your screen. First of all, please feel free to sign in to the chat bar with your name, affiliation, and preferred pronouns if you wish. We always welcome a chance to know who's in the room. For the time that we're hearing our presenters, we're going to ask that everyone turn off their video just to start and mute your audio so that we can really give that speaker our full attention. If we do have any disruptions, we'll have to handle that by putting people on mute or potentially removing you from the Zoom. We will share the link to the report in the chat following the speaker presentations, along with a statement from playwright Charlie Simpson, who has been dealing with long COVID issues, and she was kind enough to share her thoughts on the report and hopes for the report. We also have a press release that contains both of those links, and we'll share a link for that as well. This Zoom conference is being recorded, so please keep that in mind. After the presentations are done, and we have about 30 minutes of discussion planned here, we invite people to use the raise your hand feature so we can call on you to ask any questions to any of our panelists. You may also use the comment bar to submit questions, and we'll do our best to tabulate all of that and ask those questions to our panelists at the end of the session up until 3 p.m. Eastern time. Very quickly, to introduce a bit more of the subgroup and what you're going to hear us talk about today. So the healthcare access subgroup of the CWG is a subgroup made up of several organizations that focus on various issues in chronic health. And we've brought our expertise to this report to call for a long-term vision to address all of the ramifications of COVID-19, including the complications that will outlast current vaccination efforts. Gotta love a phone that rings right when you're in the middle of speaking. To quote a little bit from the executive summary, no infectious disease epidemic in history has ever been so clearly fueled by chronic disease as COVID-19. And yet over a year from the COVID-19 pandemic's onset, city, state, and federal leadership have no clear plan or process in place to properly implement the many well-proven community-led and evidence-based practices to significantly prevent and control chronic diseases that have been exacerbated or caused by COVID-19. So we're talking about individuals dealing with long COVID as an example, as well as many people with several other conditions, including diabetes, people living with HIV, people dealing with homelessness, people dealing with mental health issues that are going to have long-term consequences. And that's what this report is meant to call out. To honor those we have lost and those who remain in harm's way, we must not accept an end to this crisis that consists solely of mass vaccination, a return to prior rates of in-person schooling, and the reopening of non-essential workplaces. You're going to hear from a number of us today who helped to author this report, who are living with chronic conditions ourselves, who are trying to navigate this current pandemic and crisis. And you're going to hear us bring our wisdom, our experiences to this, and hear some of the recommendations that are in the report. We really encourage you to check out the executive summary of the report, as well as the many different pieces authored by different people on this call, to get a deeper dive into some of those recommendations, including a demand that we recognize COVID-19 as a chronic condition or a trigger of chronic conditions for New Yorkers, and accept that vaccination alone will not address or undo the damage of COVID-19. Call for restructuring and financing of healthcare and support systems, including community-driven and adequately funded delivery of support, self-care, and prevention services for all people with chronic and mental health conditions. I'd also like to call out that today some other members of our group are having another press conference calling for the passage of the New York Health Act, which was recently introduced with majority support in both the New York State Assembly and Senate. And so I think that really relates to this conversation as well, and want to elevate that here. We want to center meaningful, compensated collaboration with members of communities most affected by long COVID and other chronic conditions. Many people on this call are doing a lot of work from a community perspective, using our connections to try and elevate the work, but we're not being properly compensated, and we're going to call for that to be better centered going forward. Create, scale up, and sustain a network of wraparound services in New York City and New York State, promoted through a multilingual public education campaign on the many facets of long COVID, post-acute COVID-19 syndrome, including myalgic encephalomyelitis, chronic fatigue syndrome, and recognize housing as healthcare by providing thousands of single occupancy hotel rooms, support and enact statewide rental assistance legislation, including home stability support and the housing access voucher program, and support a broader federal housing relief package. So that's just a glimpse of what you'll see in the report and what you'll hear more from everybody today. I won't delay us more from our speakers. We have a whole host of very wise people to hear from today. And I hope that you are as thrilled to hear from them as I am to introduce them. Our first speaker is Loretta Fleming, a peer leader with Health People, who's going to introduce our conversation around people living with diabetes.
Good afternoon, everyone. My name is Loretta Fleming. I am a diabetes peer educator, leader. I am a type 2 diabetic. My mother is a type 2 diabetic. My son is a type 2 diabetic. I've been with Health People now for approximately 7 years. Health People has helped me to learn how to deal and control my diabetes. At one time, my diabetes, my A1C was in the 12s and in the 13s. And by taking diabetes education classes and diabetes preventive classes, my A1C has went down to recently a 6.2. My weight was also high. I used to weigh 378 pounds. My weight at that time had went from 378 down to 242. And my weight right now is 268 pounds. It has not been easy for me to control my diabetes, especially now dealing with COVID and other health conditions that I have. I'm also dealing with glaucoma, a eye condition. I recently had surgery on my right eye, And right now, because of the COVID, my surgery on my left eye has been postponed until maybe April or May of this year. And diabetes it's a disease, and it is something that people need to educate themselves on in learning how to control and deal with their diabetes. My mother is also a diabetic. My older son is also a diabetic. And with the education that I received, I was able to give that education to my mother and to my son. They have also lost weight, and their A1Cs have also changed. So I say all of that to say that education is the key when you're dealing with diabetes. And I truly believe that so many people would love to be able to get the education that we as peer educators and peer leaders have done in the past. I have went out in different senior centers, adult day centers, senior uh, centers in the area where I live at in the South Bronx, educating seniors and adults to learn how to control and deal with their diabetes. And so many have come to me and let me know that what they have learned in the classes that we teach have has drastically changed their lives. They have cut sodas and different carbs and rice and potatoes. They have learned how to change their diet in the classes that we teach. So I am very grateful to help people because they have not only changed my life and many of my family members' lives, but they have also changed many lives out in the community. So um, I say all of that to say that education is definitely the key. And it would be so wonderful if we can get more funding so that we can go out into many more communities, not only in the South Bronx, but Manhattan, Brooklyn, so many areas to be able to teach people how to control and deal with their diabetes. Thank you.
Thank you.
Thank you so much, Loretta. And now we'll hear also from Chris Norwood from Health People with a few additional points.
Thank you very much, Jeremiah. We wanted to begin with Loretta because we wanted to have a vision of what's possible. What's possible is to control chronic disease. We do not have to have all these people so sick all the time. As Loretta has pointed out, self-care education is very powerful. People are very confused. And when you have groups with courses with real information for them, for a range of diseases, diabetes is prominent, but hypertension, kidney disease, all these diseases associated with COVID, people will learn they'll have much better self-care. And it's not only that they will be healthier now, but it's very clear that having better self-care slashes their vulnerability to getting really sick or dying if they do develop COVID. New York City, to our shame, and this really shows what we have to fight, New York City had a 356% increase in diabetes deaths in the first surge of the epidemic. And yet, even with that, and even with all the evidence that getting blood sugar in good control can help guard people against death and complications. Neither the city or the state will pay for self-care education that's right in communities and that is proven to help people control chronic disease. That's what we have to fight for. Thank you.
Thank you so much, Chris and Loretta. And Chris took the lead on authoring a section of the report that goes even more into some of those specific needs around people living with diabetes, and encourage you to read more about recommendations within that report and more landscaping of what advocates are having to face around chronic health conditions there. Now, very happy to introduce the lead author on helping to get this report together, and a fierce advocate who can bring additional perspective on people living with ME. So JD Davids.
Hi, thank you. Thank you everyone for being here. My name is JD Davids, JD, the letters like DJ backwards, and Davids, not Davis. I'm 53, transgender, and my pronouns are he, him. Every day, I live with the three most common symptoms experienced by people with long COVID: fatigue, post-exertional malaise, known as PEM or PEMS, cognitive dysfunction, and other things. Ironically, it means I'm actually feeling slightly better over the past month, as I've been recovering from a broken ankle, because it's forced me to stay in bed about 95% of the time, lying down and looking at a tree out the window, while paying for out-of-pocket for home help I'm privileged to have resources for. Shout out for hashtag fair pay for home care. Earlier this month in the pre-surgery test for my ankle, I came up as positive for asymptomatic COVID by PCR. That's in contrast to a year ago this day, the first one where I was without fever in a 10-day span from presumptive COVID without testing. I followed the instructions of public health officials in New York and beyond, assumed I had COVID and isolated at home. Since that March 2020 illness, I've had difficulty finding words. I wear a thick blanket of fatigue that bridges emotional, mental, and physical dimensions. At times, I tire much more easily. Now that I've tested positive for my second, though asymptomatic bout of COVID, I would perhaps be eligible to join a long waiting list to go to one of the few multidisciplinary post-COVID clinics in the country. But here in New York at the clinic, they won't accept anyone who doesn't have a history of a positive COVID test. But then again, I actually still probably can't, because here's the thing. These symptoms, while vexing and at times debilitating, only intensified after I had COVID last March. Unlike many people over decades who have faced this constellation of symptoms, I've garnered hard to get diagnoses, including myalgic encephalomyelitis, known as ME/CFS, and often mislabeled as chronic fatigue syndrome, in large part because I'm white. I've been an HIV-focused research and healthcare advocate, and I have private health insurance. I've lived with all of it for well over a decade, at the level which clinicians may call mild, in that way that many people describe their experience with mild COVID as being the most sick by far they've ever been in their whole life. But it is indeed mild, as I recognize that 75% of people with ME can't work, and 25% are homebound or bedbound. Almost every chronic diagnosis I have, except probably my seasonal allergies, is known as complex. Complex, like long COVID, and like long COVID, sometimes called mysterious. Though really there's nothing mysterious about the reality we face of people experiencing a post-viral complex illness that for many may become chronic. This was predicted by disabled people and people with chronic illnesses who were talked about but not to as the COVID-19 pandemic approached and began to spiral out of control. Long COVID is not a new or mysterious phenomenon. COVID-19 is a new virus, but chronic illness, including ME, chronic fatigue syndrome, following viral outbreaks is not new, including after SARS coronavirus, Ebola, H1N1, Ross River, West Nile virus, even polio, where it may take decades to emerge. Also complex but not mysterious is the immoral gaslighting of patients who are told it's all in our heads, especially as many of us are women, queer, and or people of color. Complex but not mysterious is the absence of care for the vast majority of people who are experiencing life-change complex chronic illness. I'd say especially if they're uninsured, not white, and not in urban areas. But truly, the scope of conditions like ME and long COVID mean that even privileged people like me often can't get the right diagnoses or any specialized care, even if we are white, even if we are insured, and yes, even if we're straight white cisgender men. There's all of about 20 ME CFS specialists, many approaching retirement age in the United States, and they are now besieged with calls from desperate long COVID patients. Complex, but not mysterious, is how people with complex syndromes, including those with viral triggers, often have more than one condition with shared symptoms like fatigue, chronic pain, and neurological dysfunction. But our care, if we're privileged enough to have it, is spread across medical disciplines and a range of busy specialists, many of whom do not actually treat the fatigue, the PEMS, or the cognitive neurological dysfunction itself. And cognitive, but not mysterious is the persistent, oversimplified, and false binary storybook I'm asking you to repudiate as care providers, as member of the press, and as the friends and family of people with chronic illnesses, or as people living with chronic conditions or disabilities yourselves. That's the false dichotomy by our bootstraps oversimplification that writes off millions of humans as damaged goods and dependent burdens, saying we're either, but never both, healthy or sick, that we are either unwavering, triumphant fighters who overcome disease, or unhealthy losers who did something wrong to get or stay ill, or that we are capable and promising, or we are broker lesser thans who should expect to suffer, to lack autonomy and agency, or to die, particularly if we aren't white. Now is not the time to go back to what we used to misname as normal. Now is the time for health equity, which will only come from economic justice, racial justice, and disability justice. Even before COVID, 6 out of every 10 people in the US had at least one chronic condition. If anything is normal, it is the very human realities of illness and disability across the lifespan. It is the disabling structures of society that isolate and disregard those among us who are living with them. In our report, we say we must recognize COVID-19 as a chronic condition or trigger of chronic conditions for New Yorkers and around the country and around the world, and accept that vaccination alone will not address or undo the damage. We demand an equitable, community-led, comprehensive, and long-term response centered on addressing the chronic health conditions that created vulnerability to the pandemic or that were triggered or worsened by COVID itself. Establishing, funding, and evaluating a new model of care that ensures quality, accessible care for all who have those conditions. We have comprehensive cancer centers. We need comprehensive centers of care for complex chronic illness. ME and other complex chronic conditions are underfunded and understudied. People with ME are underdiagnosed and underserved, but make no mistake, ME CFS is not rare. An estimated 1.5 million people in this country have it, and millions more are joining our ranks or may join our ranks as consequences of long COVID. Anyone who goes more than 6 months with some of these common symptoms are thus eligible for ME CFS diagnosis. We urgently need to develop and scale up systems using an equity-based framework and the wisdom of affected communities, including but not limited to Black and Brown people, disabled people, and people living with long COVID, HIV, ME/CFS, diabetes, and mental health conditions. Long COVID studies and services must never be restricted by COVID test status or access. That serves only as a marker of privilege or luck, not likelihood of long COVID itself. In fact, in some studies, 1/3 of people with long COVID were completely asymptomatic in the usual period of COVID symptoms. There's nothing mysterious about the many, many people with long COVID, immigrants, Black and Brown people, home healthcare workers, sex workers, imprisoned people, disabled peoples, and others who are currently completely locked out of any access to care. It's the same implicit and explicit bias that has created such inequitable disparities in COVID rates, COVID severity, and COVID deaths, as well as inequities in diagnosis and care for ME, CFS, and other conditions. In December, Congress provided $1.15 billion in funding over 4 years for research at NIH for long-term effects of COVID. This funding must be used wisely and both benefit from what we know about ME/CFS while explicitly including ME/CFS patients and others in baseline setting and differentiating research to jumpstart our knowledge. Conditions like ME fibromyalgia, and others may not have a lab test that gives a yes or no answer, but they do have definitive diagnoses. Long COVID will too. And this diagnosis must be set accurately by inclusion of all affected communities in the research to learn what it is and what can be done. NIH has long neglected to invest in researching ME. It continues to remain the most underfunded disease in the NIH's portfolio based on disease burden. It's imperative NIH fund ME research as part of its post-acute sequelae of SARS-CoV-2 infection, PASC initiatives. To the leaders of my city and state, I remind you, every New Yorker has but one life. It's unique, sacred, and valuable. Now is not the time to return to a normal that writes off so many of us. May the suffering we've borne witness to, and that some of us have had the privilege, grace, or luck to survive, bring the mandate for true, comprehensive, and collaborative social, racial, and health equity for us all. Thank you.
Thank you.
Thank you so much, JD, for that rousing call to action and for us to fight trying to return to a normal that never was. I am now very pleased to introduce C. Virginia Fields, President and CEO of Black Health, who's going to share some thoughts on the needs of people dealing with mental health and racial health equity.
Thank you so much, Jeremiah, and good afternoon to everyone on the call and engaged in the meeting. I would say that Loretta and JD's story really is what we need to be moving forward in this effort, because there's nothing better than for our legislators and policymakers and people who fund initiatives to hear those stories. Very compelling, and I simply want to thank both of you. And on behalf of the National Black Leadership Commission on Health, we're very pleased to be a part of this COVID working group that has now brought this report possible. Just briefly, as many of you know, the National Black Leadership Commission on Health, our mission is about eliminating health disparities and promoting health equity with a vision for health equity for Black African Americans, since that is predominantly the population on which we focus. And we recognize that as Blacks and African Americans are addressed in this issue, every one of the populations are helped. So our mission is very clear. And when we began to hear in the beginning of this pandemic, even now, the surprise of so many in the media and in public official positions, they were so surprised that Blacks, African Americans were being impacted more by COVID, not only in the disease itself, the virus itself, but also dying. We were not surprised because that's the work that we do. What was the annoyance, and still is, to hear media or others talk about this as a surprise, because the data is there, the information is there. It is very clear that Blacks and African Americans have been disproportionately by these diseases that now we know make them more vulnerable to COVID than any other population. So we see this as a real time for action, a real time to come to arms to push for some changes. We say in Black Health, it's not enough for groups like the American Medical Association, governors around the country, mayors around the country, to declare healthcare as a racial, structural racism issue. What's important is, what are we going to do about it? What are they going to do about it? So I see this report as a very important pathway in terms of many of its recommendations, talking about addressing stigma, talking about the use of data collection, and certainly talking about the need for more funding at city, state, and federal levels. And I commend Chris Norwood for her recent report calling for the health wellness initiative centers and focusing those resources at the community level, community-based organizations, which probably most of us on the phone are a part of community-based organizations, because we're the ones out here working with the populations. We identify the needs, we respond to the needs. So moving forward, funding in order to allow us to do the work that we are already doing is critically important. And the recommendations, as I'm sure we'll be walking through them at another point in the call. But the 8 focus areas of the Black health are the ones, again, makes Blacks more vulnerable, whether it's cardiovascular disease, prostate cancer, breast cancer, diabetes, sickle cell, HIV, AIDS, hepatitis, and mental health. And so coupled with the diabetes and the COVID itself, as far as much of what JD talked about, I just want to also add the impact that we're seeing with respect to mental health. Our office has done a number of webinars around the country, and it's essential that we consider mental health as a chronic disease when we address COVID-19 policies. And I know one of the staff of Black Health, Brittany Smith, has been actively involved in making the resources and the information around mental health to focus the issue, because we're seeing an increase of the need for more mental health services. I was very pleased to hear on a webinar we hosted recently about the increased number of Black men who are seeking mental health. Mental health, we know too often in our community, has been stigmatized. But now people are understanding how all of this has played and impacted our lives, and mental health must be a part of the policies moving forward. That is why a comprehensive initiative that addresses all of these chronic diseases that have been highlighted so far, diabetes, mental health, COVID itself in terms of long-lasting impact. And we know the impact in terms of those other health focus areas. So this is our time. And the one question that we now continue to ask in doing our work of those who are in the positions to set policies, to set budgets, what are we going to do about it? We have the information, we have the knowledge, we have the people with lived experiences, and to continue to just have to issue another report without something being done, this is a disservice to everyone in terms of what COVID has unveiled. The world now knows what the impacts are. The data is there. So what are we going to do about it? And what we're now doing about it under the COVID working group is setting forth this report as a major step on the path for doing more to raise awareness, to educate, to empower, to engage, and to demand from those in elected positions who make the decisions around policies and budgets, that they respond. And I'm certain that this group is nothing new for this group. And I'm just sort of underscoring it. And I want to thank everyone on the call who has been a part of it. And through our staff member who's been working directly with the COVID group, Brittany, the role of Black health has and will continue to play in responding to what are we going to do about it. Thank you so much. And I look forward to where we go from here. Thank you, Jeremiah.
Thank you so much for another rousing call to action. There are many rousing calls to action today and in the report, and hopefully that shines through. We have one more amazing speaker who also helped author a section of the report, and Kelsey from the Center for HIV Law and Policy, who's going to talk about home care and support services, and then we'll move into question and answer, and we will paste the appropriate links in the chat at that point. So Anne, please take it away.
Thank you, Jeremiah, and thank you, Loretta, JD, and Sue Virginia. I don't know that I'm also a rousing speaker, so hopefully we don't end on a less rousing note, but the issue of home care, home and community-based services, long-term supports and services, it goes by many names, is really a cross-cutting issue, and it affects many of the issues that were raised today. It is a disability rights issue, a gender justice issue, a racial justice issue, and an economic justice issue, and the needs of both people who receive care and the needs of folks who give care and the provider agencies has really been ignored during the pandemic, and their needs have not been prioritized really at all. And what folks have reported to us is fear. The act of home care, the act of giving care in the home is an intimate one. It requires the sharing of time and space and sometimes personal contact. And in the time of COVID, that becomes extremely difficult. So some felt that they didn't want caregivers in their home. Others wanted caregivers, but were frustrated over the lack of PPE, which was not provided to individuals receiving care in the home, caregivers or agencies who had to go in and fend for themselves to find sufficient PPE. Individuals reported getting COVID from their caregivers or giving COVID to their caregivers, which both further the spread of COVID, but also further disrupted an already fragile system of care. So as we look forward into what our future life looks like, the report calls to, again, not go back to a normal that never was, as Jeremiah put it, but to think boldly and about, with justice and equality on our minds, about how we fund and prioritize home care. So that people with disabilities, our elders, and folks with chronic health conditions can live full and independent lives outside of institutions. Because of course, we've all seen the really terrible effects of COVID in our nursing homes across the state and across the country. And we don't want more of that. We want people to age or to live in their home, supported in the way that they choose. And we want our caregivers, who are primarily women of color and immigrants, to be paid fairly. And so I note that JD put the link to fair pay for home care in the chat, and I will just absolutely second that. That is really critical to have our caregivers paid equitably. And then, as well as others have echoed, to look at where our funding goes. And our state government, looks at home care as just a drain on resources, rather than an opportunity to support all of its people. So we call for increased funding for the home care system, as well as increased federal funding specifically geared towards long-term supports and services as well. So I thank you, and Jeremiah, I'll pass it back to you or to Kimberly for questions.
Thanks, Anne, and thank you. And I find you very rousing and certainly very important to bring that perspective into the space, and such a valuable contribution to the report. So I'm going to get to work to pasting the links for everybody. And for the question and answer, we're going to hand it over to our own version of CJ Craig, Kimberly Smith, for the rest of the call.
Thank you, Jeremiah. Thank you, everybody. My name is Kimberly Smith. I use she and her pronouns. I work with Callan Lord Community Health Center and have been on the COVID-19 working group for almost its entirety. I might have missed that first meeting, but other than that, I've been on this working group for the entire year. And I just want to thank all of our speakers and contributors to the report. I've read the report, obviously, having helped with the editing a little bit, and I've heard you all speak, but I feel like I learned something. I've learned definitely something new today, and each of you brought such power and compassion in your remarks, and I really truly want to thank you for that. And I also want to acknowledge that there are contributions in the report that we didn't hear about specifically on today's call. Dr. Sarit Galib wrote a section on heeding the lessons from HIV, and Shelley Nortz authored a section on housing as healthcare. So once you have those links, you'll be able to read the full report and just hopefully push it and help us advance this message. So thanks again. So at this point, we can pivot to questions. And I'm looking and I don't see any so far. I would encourage you, you are now encouraged to turn on your video if you want, and you can raise your hand or physically raise your hand, and I'll see if I can call on you to ask your question. Do we have any questions thus far? Oh, Chris Norwood would like to ask a question.
Yes, I think we should tell people exactly how they can get the report. Have we done that?
I just paid. Oh, go ahead, Kimberly.
No, you go ahead. I think you just pasted the links, and that's maybe what you were going to say.
Yes, if you look in the chat right now, you'll see a link to the press release, a link to the report itself, and a link to a statement by Charlie Yvonne Simpson, playwright and TV writer, who has been dealing with some long COVID symptoms and was gracious enough to write a statement about the report for us.
And if they, how shall I say, misplace the link, I know that won't happen, but is that on the TAG website?
So you can find all of this on a section of the COVID-19 working group website. I'll paste a specific link to that right now. You can also email me, and I'll put my email in the chat if you need anything.
Great.
Thank you. So do we have any questions from anybody in the audience or any media? I'm happy to ask a prompting question if not. We do have a couple minutes to spare, so take your time, formulate your thoughts. Oh, and
I can ask a prompting question.
Sure, go for it.
So, one thing I didn't talk about was vaccine access. And so, the garbage truck has just pulled up outside my door as it happens. So I was going to ask, what vaccine access looks like for, the populations you serve, or for your own communities, or if you have recommendations you wanted to give, because that's something the COVID working group has worked a lot on. And so I'd love to just highlight some of that, those great thoughts.
Great. Did you want to direct that question to anybody in particular?
No.
Okay. All right. Anybody want to take a stab at that? Our speakers, and I would also invite maybe if there some of our other contributors are on the call, and if they're comfortable, they are welcome to jump in and say their piece. Oh, JD.
Well, as reporter Liz Heileman noted, there have been reports of people experiencing a remission of symptoms of long COVID from vaccination. It's not everybody, and it's just starting to be more methodically looked at. In anecdotal reports I'm seeing from people with ME, it really does seem like a mix of people who are feeling exactly the same, people who are feeling somewhat better, and people who are having exacerbations of ME symptoms. I also wanted to point out that the criteria is different in different state and is rapidly changing in New York. But as far as for people now who are under 50 but may have conditions, including neurological conditions, that could cover people with long COVID. So there are people who are sort of newly eligible because they are newly having pre-existing conditions.
I'll just briefly say, being in the South Bronx, I'm sure there's vaccine hesitancy, but we're really still at the stage where people are trying to get the vaccine and they can't. So analyzing hesitancy, I'd like to get a bit further and see. The one thing that did surprise me a lot, though, is that the vaccination rate of people 65 and over is quite low. And that I thought was, something maybe we should look at more, because obviously that's a very high risk population.
Yeah, thank you. I do see a question, a raised hand. I don't want to mispronounce your name, but the initials are AJ.
Hi, my name is Anjali. I am actually a medical student at SUNY Downstate in my 4th year. And so I haven't read through the whole report, but I guess I am wondering what you all see as the connection between kind of facing chronic disease as a public health response and in the setting of lots of New York City healthcare being delivered through these mega hospital systems, and lots of people accessing their healthcare through hospital visits. So I'm just, it's something I see a lot as a med student. And I don't see clear solutions out of it coming from the hospitals. So I'm curious about where that fits in.
I think we all consider that a huge challenge. I mean, I personally call it the sickness industry. I don't think I'm alone in that term. And it's been, especially if you've been very involved in chronic disease, it's been absolutely clear. I mean, I will just say that one time I was on I wasn't on a panel, but I was at a small panel where Michael Dowling, who's head of Northwell, which is the largest system, was a keynote speaker. I can't remember exactly, but I think Northwell made between, I mean, we know they're a nonprofit, but they made between $200 and $400 million that year. And I asked him if he had even one diabetes self-management group meeting in the community where it would be accessible to people. And he said, no, they didn't have one with all that money. I'm sorry, I think that's the answer to your question. And that's a basis of what we have to focus our fight on, which is moving out into communities. Without that, it'll just be the same thing. I mean, and well, thank you.
No, that's okay. I'm going to jump in before I see that JD has his hand raised, and just say also that, there is throughout the report woven sort of a continuing thread of the importance of community healthcare. There's not a specific section on it, but I do believe it's sort of interwoven into the report. And we, I think as public health activists and advocates and proponents, we are all sort of supportive of and understand the value of community-based healthcare, primary care in community, whatever that looks like, whether it's geographic or otherwise. So I want to pass it over to JD.
Sorry. There's many of us who have been involved with COVID efforts who have a background in the HIV movement, and we can look at both lessons learned because they were done poorly and lessons learned because some things went well. When we look at what we can be doing now for chronic conditions and care, long COVID and otherwise. One thing is early on, it was real, even before we had as anything like the treatments we had now, people living with HIV who had an HIV specialist providing their care lived twice as long. And being able to have one's primary provider be also a specialist in one's complex condition, because HIV was very much a complex condition in those days, not so much of a chronic condition, but even still today, having providers that understand all the complexities of your condition or conditions. So that's one thing. Also looking at options that can come through, for example, initiatives for payers of care or wraparound care or supplemental care, whether we look at the Ryan White Care Act federally or some of the programs that Amita Care has in New York for people living with HIV, people who are homeless, and trans people who are in public health systems of care, to be able to supplement and have deeper patient and community engagement on how care should be delivered, plus seeing what it takes to actually have people, be in and stay in care. And unfortunately, what I think we may be having now is sometimes in HIV we've had happy problems, and it's terrible to call us a happy problem, but long COVID is sort of a happy problem, where we're going to have millions of people chronically ill for years, if not for life, who may even maybe the most likely to be sort of young and healthy prior to COVID, or at least not as disproportionately elderly. So younger people, similar to populations that were initially coming up with HIV, or before we even knew what HIV was, suddenly facing a very different change of circumstances and realizing how exactly bad care is when, for example, it's only available in hospitals that in a city like New York, you have to travel for hours to and may not be treated well. So I think we're looking at across social and health movements, the opportunity to really tackle, including with the help of activist medical students, a new way of looking at care and really looking at health and illness. So for example, a greater recognition that our bodies, we all have one immune system within our body, and it may express in ways that are both overactive or underactive. And that may be sliced and diced into different conditions, but what we need is one medical home. And I think we have the opportunity to work together now to fight for that, community-based medical homes backed up with medical institutions that will be of optimal health to all of us who need them.
Thank you so much, JD. I did see Shelley raise her hand, so I think that probably is where we will have to end it, and then I'll kick it back over to Jeremiah. Shelley?
Thank you so much. I just want to say that on this last point, I think this was one of the colossal mistakes with COVID, was that we, as a city and a state and a federal apparatus, did not rely very heavily on our community health centers and supporting community-based healthcare as a way to help assess, screen, triage, diagnose, and then test and vaccinate the populace. What that ended up doing was placing a great deal of excess burden on the hospitals, and it increased exposure, and it resulted in delayed access to care for the poorest New Yorkers. So we're still trying, as a matter of fact, at the Coalition for the Homeless, to figure out how to get the structures to work to get the J&J vaccine to the people that we feed 1,000 people a night plus on the streets of Manhattan and the Bronx. And we're going through hoops just to try to get vaccines to people. So a lesson for the future that we do have a good community health infrastructure, we don't support it adequately.
Thank you so much, Shelley. And again, Shelley is a contributor to the report, as is Sarit Galib, who's, I thought I saw her briefly, but she may have hopped off the call. So with that, I'm going to turn it back over to Jeremiah, who will close us out.
Thank you, Kimberly, and many thanks to everybody for coming to this conversation, for your interest in the report, and hopefully it makes for engaging reading for you. I also wanted to highlight a point that JD made about the photographer, Pato Hebert, is that how you say his name, JD? Pato, thank you. And the lovely photographs that were included in the report. So we hope that you enjoy those as well. We will be sending this out via social media. Again, it's available via the links that we shared with you. You'll see the press release there. And if you have any questions, please don't hesitate to reach out. I think with that, there will also be a recording that will make sure that gets sent around as well of this conference. Beyond that, many thanks for being here, and hope that everyone has a great day.
Thank you, Jeremiah.
Bye, everyone.
Thank you.
Thanks, everyone.
Thank you.
See, there's one more question in the chat, and I think we can figure out how to address that question. Thank you.